In this lesson, we'll review what the OT does within this evidence-based model of care with my choice participants. The objectives of this lesson are to have the knowledge and skills to provide the evidence-based model of care and to review assessment, person-centered service planning, and care processes. There are 4 phases of care. Assessment, which is observation of the participant's situation and home environment using readiness to change. In other words, the difficulty of conducting tasks, task importance, and understanding the person's desire to change. Looking at it from the participant's perspective on their performance abilities and what they view as acceptable performance levels and how former performance problems were successfully managed. The OT observes the participant performance, safety, and efficiency during tasks and occupations that are rated as important to learn new strategies. They check if the environment features or prohibits performance or the ability to initiate, sustain, and complete a task within reasonable standards of time and independence. Also, there's safety, the potential or actual risk of injury, and efficiency, performance with a minimal number of movements or physical effort. They also consider if the participant needs physical therapy, and they conduct a home tour to observe the physical areas in which the participant performs their mobility, ADLs, and IADLs. The OT validates impressions with the participant through engagement and connecting with them and their caregiver to obtain input, and together with the clinician team and participant, design a person-centered service plan to problem solve in a collaborative manner to meet the expected goals and strategies choices made by the participant. Then the strategies are enacted and evaluated. The OT uses role model to help the participant and/or caregiver enact the strategies and evaluates use and modifies the strategies as needed. Here's our first checkpoint. Which of the following is part of the OT assessment? Is it assessment of difficulty or importance, a home tour, or all of the above? It's all of these. The OT assesses difficulty, importance to the participant, and conducts a home tour. As a reminder, the OT conducts readiness for change assessment to determine if the participant is willing and ready to change prior to enacting a strategy. This helps to understand if a participant is ready to change prior to enacting a strategy. Here are the steps. It also allows the clinician to focus their time and energy on those participants that are ready to change and guides selection of strategies. Once you get used to conducting a readiness to change assessment, it usually takes less than 2 minutes. So here's the focus of OT care. The ecological model is used to guide how the person-environment fit to support independent living. OT training does not usually include use of this model to understand, then guide a plan to support the desires and needs of the participant. However, the majority of OT education guides how a person and environment fit impacts the individual's life. OTs possess special skills and knowledge to help older adults function in their homes. OT's holistic view of participants makes them uniquely qualified to assess how daily activities affect a participant's health. The focus again shifts from disease process to how the disease affects function on a day-to-day basis. For example, OTs are expert at identification of devices that will enhance balance and energy conservation, or allow a participant to feel safe in their environment in which they live. And here's another checkpoint, true or false. An OT's holistic view of participants makes them uniquely qualified to assess how daily activities affect participants' health. The correct answer is true. OTs have this holistic view. The OT conducts a home tour, which is an assessment form which includes examining the person and environment fit. The assessment of the home is based on how a person lives within the environment, and it individualizes from their perception. It includes a person-centered approach to what is important to the individual. OTs are expert at conducting an assessment and ranking the difficulty and importance of a task to a participant. So difficulty is ranked 1 through 5, with 1 being no difficulty, 2 little difficulty, 3 moderately difficult, 4 a lot of difficulty, and 5 unable to do. They also commonly rank the importance of a task as 1 to 4, 1 being not at all important, 2 a little important, 3 moderately important, 4 very important. This assessment approach guides the OT to understand the participants' issues and desires. Here's an example of an OT assessment commonly used to rank difficulty and importance and to understand how much assistance is already being used to support the participant. This is the type of assessment that the OT will be using in this evidence-based program. So the assessment is driven by goal setting. It summarizes the problem areas that are found during the assessment. The OT probes through dialogue and/or observation for details about the specific nature of a problem, how a typical day proceeds, and current strategies in place to handle the problem, like what do you do? Information relevant to the performance area is the basis for the environmental problem solving. For example, if the performance area is meal preparation and cleanup, the OT educates about causes of this problem. During problem solving and brainstorming, the OT examines the positive and negative factors influencing performance. For example, the OT can help the participant analyze performance of meal preparation cleanup, naming factors that support or do not support performance, including factors that arise from the participant and/or the caregiver and the environment. The OT can offer examples to facilitate the discussion. Through the discussion, they agree on goals to address that are the performance problems and help the participant to apply principles of safety and energy conservation to the performance area. Together, they decide on strategies to achieve the goals for a person-centered service plan to address these performance issues, and then practice the strategy using demonstration, simulation, and role play. Here's another checkpoint. During problem solving and brainstorming, a OT examines the positive and negative factors influencing performance. The answer to this is true. It's highly effective when done with the participant. The OT also focuses on devices and home modifications. Decreasing falls using railings, grab bars, taping rugs and bath mats, bath safety strips, poor lighting, tacking cords, step and walkway repair, clutter issues, floor repair, and proper footwear are key. Improving safety mobility through transfers from the shower, chair, or tub bench, or the chair and bed risers and cushions and bed rails have also been found to be highly effective at home. Improving ADL independence for bathing, dressing, grooming, hygiene, feeding, sleep, and sexual activity. And also improving IADL independence for meal prep, laundry, vacuuming, bed making, washing dishes, telephone use, financial management, grocery shopping, or taping medications, or caring for others, and social, leisure, or volunteer activities. They also focus on improving home safety through repairing locks, doors, water issues, electrical issues, smoke detectors, fire extinguishers, outlet usage, ventilation, doorbells, and exposed wires. What the OT does is they use the usual process for obtaining equipment and or home modifications within the My Choice program at your waiver site. Home modifications are also key. Similar to the devices, they also use the usual process for obtaining equipment for home modifications. So one of the strategies that OT uses for goal attainment is improving the participant's ability to analyze issues within a performance area. What they do is they validate impressions with the participant and then discuss their desires and needs in relation to the environmental solutions. They can educate on safety and energy conservation in the home to eliminate or mitigate environmental factors in the home that might cause injury, or help the participant work more efficiently to compensate for poor endurance, unsafe mobility, and weakness. Safety and energy conservation strategies serve as the basis for environmental modifications developed to address specific ADL, IADL, and functional mobility performance problems. The OT can discuss what has happened between contacts during home visits and use probes and active listening to elicit details. The OT can also examine what the participant did to address issues within a performance area, how they felt about their skill level, and the perceptions of actions on the frequency and severity of the performance problems. They can also observe the participant performing the activity or task using these prescribed strategies. What's also helpful is when the OT refines understanding of the environmental influences on the issues in the performance that are identified as problematic by the participant and what they wish to modify. So here's some examples of case studies of real-life My Choice participants who received OT care using this evidence-based model during our pilot study. Case 1 is a 57-year-old female who lived with her husband and son. She had MS, depression, anxiety, hypertension, and hyperthyroidism, and chronic pain, which affected her daily life. And she had a recent below-knee amputation. Upon OT assessment, building a relationship was difficult because she was having difficulty adapting to her amputation and prosthesis. And wheelchair maneuver in the home was difficult. She needed a trapeze for bed mobility, and there was a great need for interdisciplinary coordination. To feel more independent, she obtained a raised cushion on her wheelchair and a shower bench with a bath mat after being evaluated by the OT. Her person-centered self-directed care plan outcome was to increase her safety and independence. She had a dressing stick and reacher, but did not know how to use them. So through cognitive behavioral therapy and role modeling, the OT helped her achieve independence with dressing using these two devices. She also had unsafe transfers. The team and the participants strategized to perform transfers using a grab bar, locking the wheelchair, and then taking the time after role modeling and motivational interviewing were used to increase her safe transfers, and she had no falls since using this new strategy and approach. She also wanted to build her strength and balance to stand independently. So a plan to exercise to increase her blood flow and keep her muscles working through the use of motivational interviewing was devised. The outcome was that she was eventually able to stand with the walker after a couple months. This participant reported the care gave her more willpower, and that was very useful and improved her independence. This case was very successful. In the second case, this is a 77-year-old female who lived alone in a trailer and had Parkinson's, diabetes, coronary artery disease, heart disease, depression, anxiety, hypertension, dementia, arthritis, peripheral neuropathy, TIAs, incontinence, and chronic pain. A very typical My Choice patient. The OT observed her having difficulty ambulating in her home with a U-step walker, and she also desired to sleep in her bed rather than in her recliner. She desired to feel more secure getting in and out of bed, and a person-centered, self-directed care plan was devised to build her self-efficacy. They obtained a car step, demonstrated and practiced, and now she's able to independently get in and out of bed. She also had low toilets, which prohibited use. So through the use of person-centered care planning and motivational interviewing, they were able to place a commode over her toilet to use with grab bars, and she was able to independently toilet. Through care planning, they built her self-efficacy and used interdisciplinary coordination to work as a team. The participant also had a desire to feed herself, and they obtained computerized utensils. However, they didn't work very well. So they modified the plan and obtained weighted utensils, and through role modeling and use of cognitive behavioral therapy, the participant was able to begin feeding herself independently. Each and every one of these were life-changing, quality of life improving events for this participant. In the third case, this is a 74-year-old female who lived alone in a house. She had diabetes, coronary heart disease, depression, anxiety, hypertension, and peripheral neuropathy. Upon home assessment by the OT, she found there was difficulty with time spent maintaining her home and keeping the environment safe. The front steps had sunk and could no longer be utilized due to the depth from step to step and the lack of a railing, and the garage step was loose and unstable. Sometimes the garage door would not work, leaving the participant without a safe entry and exit. Railings on the stairs leading to the bedroom and bathroom were also loose and pulling out of the wall, and there was a leak in the bathroom shower area deteriorating the wall where the faucet was located. There was also concern about the roof and eaves. The participant did not have the funds or a family to help with any of these issues. Through interdisciplinary coordination, resources in the community were identified to provide the repair, but this was not successful. The team was able to provide the needed repairs for the established medically necessary items for safety reasons. And the outcome of all of this was that builders completed repairs for about $1,100, and the participant was now safely able to enter and exit her home and go up and down the stairs to her bedroom and bathroom. So, through building her self-efficacy and role model, the person-centered service plan was met to the participants' desires. In summary, an evidence-based model of OT care includes use of the principles and techniques and approaches within this care model. The OT assesses difficulty and importance, the home environment, and identifies the participant's desires within the OT discipline ability. A person-centered, self-directed care plan is designed, tailored to the individual's needs, leading to care that improves the quality of life of My Choice participants. Thank you.